Hello, everybody. This is Dr. Lloyd again for the cardiovascular system, chapter 18. We do this in two sessions, chapter 18 and 19. So let's begin. Okay, the heart is four-chambered. You've got the right heart, which pumps to the lungs, the left heart, which pumps to the systemic circuit. Now, on the right, there's a diagram of blue and red. And of course, we know blood is always red, it's never blue, but physiologists draw this diagram to represent deoxygenated and oxygenated blood. Okay, so we can start on the right heart, which pumps to the lungs. The right heart, the pulmonary arteries carry deoxygenated blood. That's one of the exceptions to the rule that arteries always carry oxygenated blood. And the pulmonary veins then carry the oxygenated blood back to the left heart. The left heart then pumps the oxygenated blood to the systemic circuit, where it's exchanged, and returns then to the right heart, where it pumps back to the lungs to exchange the gases. There are a set of valves. We're looking at the atrioventricular valves between the atria and the ventricles. There's a tricuspid on the right heart and a bicuspid, or what's called the mitral valve, on the left heart. We've got a vascular wall on the outside with a septum in the middle of the heart. And you can see that the left wall is much thicker than the right wall. The right wall is much thinner. Even though they process the same volume of blood, the pressure is indeed different. And this thick myocardium indicates the left side that will develop much more pressure than the right. All right, there are certain areas where you can use a stethoscope to listen to heart sounds. Using the mid-sternal line, you can make up the right second rib. That's one. There's also the right rib near the diaphragm. Left will be near the sternum, and then near the apex. So if we take a slice through the chest, we go through the mediastinum, which is a serous-filled cavity that contains the heart, and we can see the thoracic compartment, the left and right lung at this slice, posterior being the back, anterior being the front. So let's look at the layers. The endocardium, that is the layer that comes in contact with blood. The myocardium is the meaty internal portion. Then we have the epicardium, which is made up of a visceral and parietal layers that make up the pericardium. The pericardial, the serosa that makes up the pericardial cavity when it folds. So we've got our visceral and parietal serosa. And then the outermost layer is also part of your pericardium, but it's called your fibrous pericardium. So up here we can see a little chunk. So we have got our endocardium, which has the contact with the blood vessels, the myocardium, which is the extent of the metabolism going on in the heart. That's where all the force is happening. And then the epicardium, which is the outer portion. Okay, if we look then, let's look at the right heart first. We have the vena cavas that empty into it, the superior and inferior vena cavas. And when there's actually an electrical node up here as well, which is not seen. But when the atria contracts, uh, the blood flows into the right ventricle, and we can see the tricuspid valve. It's being held open by trabeculae carneae and papillary muscles, which are these large muscle branches at the bottom. The tendons are called chordae tendineae. These hold open the valve. This is the tricuspid valve. In the right heart, we can make out the trabeculae carneae. Looks like little pieces of meat. And then when the right ventricle contracts, blood ejects out of the pulmonary valve. This is called the semilunar valve because of the way it looks from the top. And then out into the pulmonary trunk, out to the heart, and then the heart is going to return I'm sorry, into the lungs, and the lungs are then going to return the blood to the pulmonary arteries, which dumps it into the left heart. Okay, so we are now at the left atria. When it contracts, blood flows into the left ventricle, which is being held open by these large papillary muscles um, and the chordae tendineae. This is the mitral valve. This valve on the left side is often blown out due to systemic hypertension. And then when the left ventricle contracts, blood ejects out the aortic valve, another semilunar valve, out into the arch. From the arch, um, there are three passageways which we'll go through. Well, actually, there are four, but three immediate. Actually, there's an initial passage to the heart itself, which we'll look at. Okay, so branching off of the aorta are the coronary arteries, and we can see here um, part of the left main, which is under what's called the uh, left auricle of the atria, and you have a right uh, auricle as well. So the blood, firstly, from the systemic circuit, flows into the heart, and so the blood feeds itself first, very important. And we've got a left main with a circumflex. This is the location of the widowmaker uh, defect when there is a plaque of coronary artery disease. In this location is very dangerous and can lead to sudden cardiac death. And then we've got the left anterior descending coronary, tightly coupled with the great cardiac vein. On the right side, it has its own coronary, right coronary vessel. These are the vessels that are going to undergo treatment with coronary artery disease, whether it be a angioplasty or a stent or some kind of anti-clot buster drug. Okay, let's take a look at the posterior surface. We can see the coronary sinus, and this is what the deoxygenated blood from the myocardium collects in and dumps into the vena cava. Okay, um, let's see. Okay, let's go on. I talked about the semilunar valves, and when you're looking from the superior, you can see these valves kind of look like these. There's the aortic and pulmonary valve, look like little moons, and so they're called semilunar. We look at the cuspid valves, the tricuspid on the right side, the mitral valve or the bicuspid on the left side. So the atrioventricular valves are located between the atria and the ventricles. The semilunar valves are located between the ventricles and the major arteries that they pump into. Okay, this is a real nice picture. Looks like a backlit showing papillary muscles and chordae tensionae. This valve looks like it's closed, and this is maybe a left ventricle. And we've got a cadaveric picture, which really shows how most of the heart is left ventricle, and then there's an appendage for your right ventricle, and it shows how most of the heart is developing pressure with the systemic circuit. Okay, so the function of the atrioventricular valves, as the blood is returning to the heart, it fills the atria, presses against the AV valve, opens it, and the ventricle will passively fill even before the atria contracts. But as the atria contracts, it forces the rest of the blood into the ventricle. And then we've got the right side, which forms a similar path, but uh, we've got the atrioventricular valve or the mitral valve that in this key is closed as the heart is contracting. So there are two semilunar valves. There's a pulmonary valve located between the right ventricle and the pulmonary trunk, and the aortic valve located between the left ventricle and the aortic trunk. There are two cuspid valves, the tricuspid on the right side, the bicuspid on the left. The bicuspid is also called the mitral valve, which is the left atrioventricular valve. I would put all this on flashcards because there are two or three names per valve. Okay, so the function of the semilunar valves, uh, this is where one of your heart sounds is going to come from when they synapse shut. But as the ventricles contract with the increasing ventricular pressure, the semilunar valves open and the heart forces blood through that circuit. Um, when the systemic circuit exceeds uh, the cardiac circuit, you'll have closure of these semilunar valves. Okay, so the heart is a double pump, pumping at the same time the right side and the left side. And so let's take a look at the action. So first we've got deoxygenated blood returning to the right heart, fills up the right atrium. There's contraction to fill the right ventricle. When the right ventricle contracts, blood is ejected out of the pulmonary valve into the lungs, where oxygenated blood is then carried into the left atria, where the left uh, atria contracts and fills the ventricle. The ventricle then contracts, exceeds the aortic pressure, and squirts into the aorta. Then the aortic pressure exceeds the ventricular pressure, and the semilunar valves snap closed. Okay, here's another slice showing how most of the heart is the left heart. You can see the myocardium of the left heart uh, is is most of it, and then there's just an appendage for the right heart. They do contract in concert. So atrial systole corresponds with ventricular systole. Okay, another look at the coronary circulation, which branches off of the aorta. We've got our left coronary. This is the left main. It then divides into the circumflex and the left anterior descending. And then we've got our right coronary artery and a right marginal artery. The coronary arteries will perfuse the heart, and then blood is collected into the coronary veins and into the coronary sinus. Okay, so the heart itself is an organ that will beat all together. It's called a functional syncytium, a single cell with multiple nuclei, but it's really all the cells contracting together through intercalated discs, which make up gap junctions, which are electrical conductivities, so that when one cell contracts, its neighboring cell will contract. It'll depolarize as well. And then we've got desmosomes that are like the cell Velcro that keeps the cells from pulling apart. So functional syncytium refers to the uh, myocardium contracting together, each cell contracting together through these gap junctions. Okay, looking at the cardiac anatomy, um, there are multi-mitochondria, which you'd expect in cardiac cells, just like skeletal cells, because they are very oxidative. They're very dependent on um, oxidative phosphorylation for respiration. And also, there is a calcium need, and with the calcium need comes a branched T-tubule system so that each cardiac cell is bathed in calcium at the right time. Now, cardiac muscle is striated, just like skeletal, and so uh, there are banding patterns. Okay, let's compare. So, skeletal versus cardiac. Skeletal, striated, long, cylindrical, multinucleated. Cardiac is also striated, but they're shorter. They're not as long myotubes as the skeletal muscle. They're shorter and branched, and just 1 to 2 nuclei per cell. Gap junctions present? Yes, in cardiac. You've got this functional syncytium. So gap junctions are present. They function as a unit, yes, the functional syncytium. T-tubules are very wide in the cardiac versus very abundant in skeletal. Let's see. We won't go into other supplies of ATP. Okay, here's a good one. So, cardiac are very aerobic. They're very dependent on mitochondria for their cell respiration. Okay, let's take a look at the uh, pacemaker cells, which are present in the SA node, AV node, and Purkinje's. Uh, each of them having different biophysical properties, each channel. So here we're looking at a cardiomyocyte that is resting around -60, but it's spontaneously depolarizing, and this is due to the sodium entry into the cells mostly, and closure of potassium channels that's occurring. So once again, sodium's on the outside, potassium's on the inside of the cell. So when the sodium channels open, sodium will rush into the cell and will depolarize it. That's a negative cell plus positive ions will depolarize. That means it goes towards the positive. So as the sodium is rushing in, the potassium leak is also decreasing, and we're depolarizing. We hit a threshold, then these calcium channels open, and uh, we hit our plateau to initiate contraction. And then we've got calcium efflux, mopping up of calcium, um, and opening up potassium channels at the hyperpolarizing portion. And then we start this pacemaker potential again. And so at the SA node, these pacemaker cells will pace you between 80 and 120, maybe 60 to 80 beats per minute. Now, if the SA node pacemaker cells are not functioning, there are cells that spontaneously depolarize in the AV node, but at a slower rate, maybe 60 to 100, 40 to 60, 40 to 80. And then there are some pacemaker cells in the ventricular wall, which will pace you even less, maybe 20 to 40 beats. So let's look at the electrical pathway. We've got the SA node, which contains um, both cardiac and nervous fibers, and the AV node. AV node then travels down these bundles called the bundle of His, or bundle branches, left and right bundle branches, and then um, into the wall with the Purkinje fibers, which are then going to initiate the actual contraction of the myocardium from the apex. Okay. So the heart is innervated by both the sympathetic and parasympathetic systems. If you remember, cranial sacral was the parasympathetic, uh, and thoracolumbar is the sympathetic. So the parasympathetic is mostly going to travel down the vagus nerve through uh, through a number of nuclei of different portions of the brain. And the parasympathetic is going to be mostly inhibitory, so it decreases rate. And then we have the sympathetic through the sympathetic uh, ganglion, innervates the SA node, AV node, and also the Purkinjes. So the sympathetic activation will lead to increased rate, but also increased contractility. And you can see this by the different innervations. Okay, the cardiac myocyte that is resting at, let's say, minus 85 or something, and it's resting because of the potassium leak and maintenance by the sodium potassium ATPase. There is activation and depolarization due to open of sodium channels, sodium influx, until you hit a plateau where your slower calcium channels then open and you get calcium influx. And we've got contraction now. And then sodium channels start to close, and calcium is also mopped up. This leads to hyperpolarization and less tension development. You can see the overlay of the tension development. So as we depolarize, we start to develop our contraction, and as we hyperpolarize back to baseline, we relax. So the contraction would be systole, and the relaxation would be diastole. There is a refractory period where no subsequent stimulus will lead to another action potential. That is very important to keep these to keep this functional syncytium from going into ventricular fibrillation, where you're not really pumping blood, you're just contracting and relaxing at different rates. Okay, so let's look at the electrical activity with the leads the EKG placed. You first have an upwards deflection, which is showing actually a downward movement of the electrical activity um, uh, towards the apex. So this is atrial contraction for the P wave. The PR interval is the time it takes for the uh, uh, atria to activate contraction of the ventricle through the bundle branches. And so the QRS complex, that's the contraction of the ventricle. But also you have atrial repolarization during this phase, but you can't see it because it's obscured in this complex. You then have the ST segment, which is the difference between ventricular depolarization and repolarization. And so we've got uh, another inflection here. And then this is all in a rate. So we've got 1 beat within 1 second. That's about 60 beats per minute. Okay, so now we can correlate this with blood flow and contraction. So P wave, contraction of your atria. Um, then you've got electrical conductivity down the bundle branches into the ventricle where you have contraction. That's the QRS complex. And repolarization, which would be the T wave. Okay, let's look at a EKG tracing or ECG tracing. This is probably around 10 seconds or so. 1, 2, 3, 4, 5, 6, 7, 8. So 8 looks like maybe, actually this is probably a little less, but probably around 60 to 80 beats per minute. But you can see a P wave, a QRS complex, and a T wave, and then a P wave, QRS complex, a T wave, and a nice rate. This is dubbed normal, or it's dubbed sinus rhythm. And let's see, you can also see an arrhythmia from breathing, which is just sinus arrhythmia. So when there's some kind of problem with the SA node, two things happen. First of all, the P wave disappears, and then the rate is less because you're being paced by the AV node, which will pace the heart at between 40 and 60 beats per minute. So we've got decreased rate within this given time and no P wave. So this is junctional rhythm, form of block, where the SA node is blocked. Okay, then we've got secondary heart block, where the AV node fails to conduct some of the SA node impulses. And what you get is these P waves that kind of appear outside the cycle. Here's a P wave and then another P wave here. A P wave and another P wave. So you got the extrasystolic P wave. And so that's secondary heart block. So the heart is not quite communicating. Ventricular fibrillation. This is like re-entry. So because it's a functional syncytium, when one portion contracts, the other portion will contract. And so when there is lack of electrical activity, organized electrical activity in the SA node and AV node, or lack of oxygen, you can get ventricular fibrillation, where there's really no pumping going on. The heart is just beating haphazardly and not doing much work. Okay, this is a very important figure. Let's zoom in on it. We've got the electrocardiogram at the top, aortic pressure in green, ventricular pressure in blue, and atrial pressure in purple. And so you can see that the aortic pressure decreases during diastole as the heart is filling. There is a period of systole where the blood is not ejecting yet. You've got isovolumic ventricular contraction. Then we've got the ejection phase. This is actually the lub, or closure of your mitral valve and your tricuspid. And then the dub on the second phase is also isovolumic, but as soon as the aortic pressure exceeds the ventricular pressure, that atrioventricular valve snaps shut, and that's your dub, lub dub, lub dub. And then you look at volumes, the ventricle passively fills and then ejects during systole, passively fills during diastole. And heart sounds. We've got the four places I showed you earlier, but um, the aortic valve um, on the right superior, right inferior, tricuspid, left superior pulmonary valve, and the mitral for the left inferior, right at the apex. Okay, factors determining cardiac output. So cardiac output is the stroke volume or the volume uh, held within the heart during diastole times your heart rate. So the number of times your heart is going to contract. That's cardiac output. Now, stroke volume is a combination of your preload, so the end diastolic volume, as well as what's left in the systolic. So with increased contractility, there's actually in systolic volume because you're contracting more. With increased venous return, there's increased diastolic volume from filling. Both of these are going to increase stroke volume, whether you're increasing contractility or increasing venous return. And then on the nervous side, the sympathetic is going to increase rate, the parasympathetic will decrease rate. So the cardiac output is stroke volume times heart rate. So let's look at the fight or flight response. Look at um, norepinephrine signaling. Norepinephrine binds to its receptor, which is a beta adrenergic receptor, activates different GTPs. This allows amplification down the cascade. Ultimately, you're going to liberate calcium from intracellular and external or extracellular sources, which are going to increase your force of contraction. So this is how norepinephrine works when it's released. All right, during development, there's a concert of activities that goes on, but you've got a couple tubes that folds and forms your four chambers. It's very interesting, very complex. The heart is the first organ that's functional um, at around day 40. And then if you look at the cardiac muscle, it's also elegant in its fibers, showing how it was once straight and then it looped during development. Okay, a number of defects that can occur. These are congenital defects, so sometimes they occur within families. Uh, Ventricular septal defects. These are the defects in the septum, and you're going to get movement from the high pressure left ventricle into the low pressure right ventricle. And so that's going to be mixing of deoxygenated and oxygenated blood. Sometimes these babies come out a little bit blue, about 1 out of 500 births. It can also happen on exertion, where their lips and mucous membranes turn blue. And once again, that's not the color of the blood. It's just it is a it is the connective tissue in response to the decreased oxygen. And then you have coarctation of the aorta, which is narrowing of the aorta, and this is just resistance that the heart has to push up against. The heart will hypertrophy or enlarge because of this, but 1 in every 1,500 births. Then there's a collection called tetralogy of Fallot. Tetralogy refers to four. So the pulmonary trunk is too narrow. There's a hypertrophied right ventricle because it's pushing up against the pulmonary trunk. There's a ventral septal defect, which you get some mixing of oxygenated and deoxygenated blood. And then there's regurgitation in the aortic valve where it opens from both sides. Okay, that's the heart in a nutshell. I'll see you for the next chapter. Bye-bye.